Hello, everyone. Welcome to, I guess I'm counting, it's my interview number 5 after my last one with Dr. Mona Saleh from Australia, although she's moved international now. Today, I've got Amy Pearn with me. She is from Western Australia, which is far, far away from where I am. That's like 4 hours of travel. And I am so obliged to have her here today. Thank you, Amy, once again for your time. I know how busy you were, but thank you so much again for being here and for sharing all your experience and information with us.
My pleasure.
So, to begin with, to let you know a bit about Amy, she is the founder of the Gene Council. She has a website. You can have a look at it on her LinkedIn profile and also through her Instagram account. She provides specifically cancer genetic testing and counseling services. But she also has years of experience. I guess it's over 10 years of experience. She has a master's in genetic counseling from University of Newcastle, Australia. That university is not providing the course anymore, just for FYI to everyone. And she is a certified genetic counselor since 2005. I think what's very interesting when I was reading about her is that she is not only a genetic counselor who practiced in Australia, but she is a genetic counselor who's practiced internationally. What I mean by that is that she is a recognized genetic counselor from Board of Australia and also from Canadian Association. But she's also practiced genetic counseling in Switzerland, I guess, from what I've known, which is very interesting. I've myself thought about, if I get selected for a graduation and if one day I become a genetic counselor, I've always thought that I would love to practice in more than one country and, serve Australia, but also maybe one day go and serve India, which is where I am from. So I'm really looking forward to know from Amy how she managed doing that. She has practiced in public health, research, laboratory environment, and consultative counseling roles in all these countries. In 2010, she permanently moved to Perth, where her roots are from. And since then, she's been practicing in Perth, Western Australia. So like I was saying, she finds real interest in cancer genetics. And I believe we will get to know a lot more about specifically cancer genetics today when we will be talking with her. But apart from this, she finds really interesting and she finds value in getting more recognition to genetic counseling as a profession and making it more multidisciplinary by, I guess, collaborating with more departments and, making the knowledge more available for patients. So yeah, that was a very, very, very interesting bio about Amy. Well, Amy, I would just like, maybe I've given so much information about you, but I would like you to probably just let us know how you actually got into genetic counseling, I guess, and what did you do to become a genetic counselor?
Yeah, that's an interesting question because it's been a really long and winding road for me. I think a reasonable number of genetic counselors, my background is in hard science, but as you probably know, people come to genetic counseling from so many different areas of health and science and medicine and social work and counseling. But my undergrad was in biochemistry, and I had the opportunity to do an exchange year in Ireland, where I could no longer do my usual drama classes as electives. I had to do a genetics class as an elective. And we had a woman from a family impacted by Huntington's disease come and speak to us about her experience of having genetic counseling and actually eventually deciding not to have genetic testing done. And at the time I was starting to realize that I'm not actually very good at doing lab work. Anybody who's ever seen me cook knows that I'm a cook, not a baker. I don't like to measure things. And that was starting to become apparent in how I worked in the lab. But I always loved talking about science and sharing what I knew with people and was really passionate about that. So it seemed to me like this genetic counseling might be something that I could do and would be good at. At the time, the Canadian programs, which similar to here, there were usually around 2. I think there's 3 at the moment. Didn't take people straight out of undergraduate. And so I took some time to do some volunteer work and get my feet wet in a few different areas. But realizing that the school year was different here in Australia, and I was a bit impatient to get going, applied for the program at the University of Newcastle, which was a wonderful program. I still have some great friends from my time there who I now know as colleagues, which is great. But was sad to see that it unfortunately didn't make the uni enough money, I think, in the end. But we're very lucky to have the UTS and University of Melbourne courses. They're both wonderful, and I know both of the directors are amazing genetic counselors, so the students are very lucky. So when I eventually got that master's, I faced the joy of the Australian Immigration Department and missed a few deadlines and ended up going back to Canada, where I'm from originally. And as an overseas trained genetic counselor in the early 2000s, without any work experience, I ended up having to think outside the box a little bit. And so I took jobs anywhere I could get my hands on them. I took a position in the molecular genetics lab in Vancouver that was tied in with the maternal serum screening lab there. I took a research and sort of summer student position at the BC Cancer Agency. I worked unpaid for 3 months on Vancouver Island in the genetics clinic there to get my logbook back together, and eventually got a job in Saskatchewan, which is where I finished off my logbook and got to write the Canadian board exam. So I had to do a lot of justifying that I was eligible to write that exam. It wasn't straightforward. People didn't usually go and train overseas and then come back. So it was, not totally straightforward, but really pleased that I did it. Had the opportunity from there to take a job in New Zealand at the Familial Bowel Cancer Registry, or Familial Gastrointestinal Cancer Registry. And that really got me specialized in that year in bowel cancer in particular, but really validated for me that I really wanted to specialize in cancer genetics. That was where my interest lies. I guess the time frame for cancer genetic counseling and sort of the process and the way it works can be quite different in different areas of genetics. Prenatal can be quite a roller coaster. Familial cancer can be a bit of a slow burn. So it suited me a bit better. And I'd been keen to come back to Australia ever since I left, with my grandma being from Perth and having done one of my student placements here. I was really keen to get back to the clinic here. And luckily one of my classmates was the head genetic counselor at the time, and she said, I've got some jobs coming down the pipeline, put in an application for them, and eventually, just as I was about to ship all of my belongings back to Canada, managed to get a position in Perth and reroute that all of my stuff to come to Perth, and was in public service in the public genetics clinic in Perth for 8 years, and I think got to a point where I wanted to spread my wings and do a few different things and access a couple of different opportunities. So since starting the private practice, I still do my clinical work, but I also do research work with a couple of different organizations that have branches of studies in WA. I do speaking engagements. I'm doing some policy work with our professional body, the Human Genetics Society of Australasia. And it's really letting me use my skills as a genetic counselor and knowledge and experience in a lot of ways that I'd never really expected. And that's something I think we're, I guess, facing as a profession is how we define ourselves. It's no longer just clinical genetic counseling work. There are so many different areas and different places where genetic counselors work. The brief stint I had in Switzerland was as an unpaid intern for the World Health Organization, writing a paper on developing medical genetic services in developing countries. So when you are forced, perhaps in some situations, to think outside the box, it's amazing where you see how our skills can apply in really broad and interesting work environments. And I love seeing that that's becoming less of a, I guess, outlier, and a lot more people are doing work in a lot of different ways.
Yeah.
Well, I
Well,
feel like I did a lot of talking just then. I hope that answered your question.
it was, yeah, I have only one word. It's a roller coaster. What,
Yeah.
yeah, like everything you've said, it's like boom, boom, boom. It was a proper roller coaster experience
Mm,
that you seem to have evolved from, and it's very interesting what all you did, how you managed doing it internationally, and I think it's really good for us to know how you can actually go ahead
mm,
looking for an option like that in
mm,
future if you want to practice in more than one country. Like I said, I have that in my mind, and whatever you said has actually helped me. And
mm,
you said it so good that it's the force situation where you had to
mm,
think outside the box. And I guess these interviews that I'm doing has come out as a forceful situation for me as well, because I applied last year for UTS, and unfortunately, I wasn't selected.
mm,
I think it was also because it was my first time when I applied, and I probably took it a little easy, thinking that,
mm.
I can get it. And that's the situation which forced me to create a social account related to
Mm.
genetic counseling awareness, connect with people from US, from India, and from different countries. Sit in the night at 2 a.m. and do webinars from maybe San Francisco or New York,
Mm, mm,
and do these interviews. And I'm finding it to be a very good resource. Um, and I'm happy that a lot of the listeners have also actually given the same feedback, that
oh,
whatever
great.
you genetic counselors are sharing over these interviews have actually given them insights, away from the small little bubble knowledge that they had in their
Mm.
head about this profession. So thank you once again, and that was a very good introduction to start with. I am so excited for our next question. So because you said that specifically your main interest is in cancer genetics,
Mm.
and I've often heard from many people or many other genetic counselors that cancer genetics can be very different in terms of the culture and the environment compared to maybe prenatal or
Mm.
the other areas of genetic counseling. So can you tell us a bit about how cancer genetic counseling is different? um,
Yeah. That's a really interesting question. I think compared to fields like pediatric or prenatal um, genetic counseling, cancer's got a lot of similarities to cardiac genetic counseling in that a lot of the genes you work with will have the same kind of inheritance pattern, and a lot of the I guess information giving portion of what you would do in genetic counseling, you're not learning a new condition, you're not learning a weird inheritance pattern. And one of the reasons I like that is that I can then focus my attention on the psychosocial aspects of that session, because I know my cancer genetics well. There's always things that will surprise me, and I will never stop learning new things, and there will never be a time when there aren't things that come up that I haven't seen before. But it just I feel like gives me that little bit more leeway. And I know that we provide, somebody said it in a talk recently, hope is one of the most important things we provide to people. And I think we do that in a lot of different areas
mhm,
of genetic counseling. Um, I find that I like the way we can change care for families.
mhm,
I find that really hopeful, more so than I do in other areas. And I think that might be one of the things that draws people to different areas of genetic counseling, is that where do you feel like you're giving people the most hope? Where do you feel like you're having the most impact? And even in the last 15, 20 years, the changes in cancer care that have come about because we know more about the genetic etiology, even of sporadic cancers. It's changing treatment, it's changing surgeries, and it's really got a huge impact, and always had sort of the more historical benefit of prevention for family members. And that's been I think really rewarding to work with families and know that even if we find something that's not necessarily what you would hope to have running in your family, a lot of the time there's something we can really do to modify that risk and keep people well and change some of the horrible family histories, change that picture that we've seen. So I think that's what's drawn me to it. But, I definitely think there's great value in all areas of genetic counseling. I think we're really critical in pretty much all areas of medicine now. But that's the one that, I guess floats my boat the most.
Well, that's good to know, Amy. So moving forward, we've been hearing a lot about the initiatives that the Australian government is taking to move people more towards regional areas of Australia and increase the awareness of probably studying in regional Australia or working in regional Australia. So genetic counseling itself being such a I guess a niche area of practice in professional, because it's not still known by many people. They're not, I guess they're not those many jobs, but also there are not too many courses, in terms of universities that provide it. What are your views on, anyone who wants to become a genetic counselor or work from a regional area of the country? How has that been for you in terms of maybe the patients that you get, maybe the kind of support you've been getting and the resources that you've been getting?
That's a really good question, because Australia is a really big country and not dissimilar to Canada, where we're all squished along the bottom and there's big remote areas up top. We're all squished around the edge and there's a lot of remote bits in the middle and up north. And it can be really hard to deliver service to such a vast area. WA is textbook for that. One major metropolitan center and everything else is regional or remote. I think the public service in WA does a really good job of that. They run a lot of outreach clinics. And something I've always been a huge advocate for, both in Canada and here, I did a lot of work in Saskatchewan with Telehealth, and in British Columbia as well. You actually see my name on a paper about telehealth delivery of genetic counseling in British Columbia, from a million years ago. But that's one of the reasons I set up my private practice the way that I did, is because it provides access for people who live regionally or remotely. I've definitely seen people from not even just all over WA, but also from other states that may not have access to a private service. I may not know the other specialists as well in other states, but it means that I can work with that person and with their doctors as best I can, to provide a service that they might not otherwise be able to access. But I think the public services all do a really good job of covering regional areas. People might have to wait longer for an appointment, or telehealth has definitely, especially post-COVID, become a lot more acceptable. And I also find it improves access for people who are undergoing cancer treatment as well. There can be, obviously you can get whacked around a bit by having chemotherapy and not necessarily feel well enough to leave the house. Or even sometimes people who had a diagnosis a long time ago don't necessarily want to go back to a hospital or a clinical setting. It brings up a lot of things. Apologies, there's a cat in the background. Brings up things that they'd put behind them. So I find it's a really interesting dynamic working with people when they're in their space of comfort and I'm in my space of comfort, and we can work together from there. I think it's one of the big benefits of telehealth, even though it's got some limitations. I think it's a fantastic way of working, and patients really like it because of that extra accessibility.
Yeah. That's fantastic. I think we just touched upon another very good topic, which was telehealth. Because like you said, I think not many of us knew about telehealth being a source of genetic counseling before COVID. But after COVID, a lot of us have actually begun to read about telehealth and about telehealth counseling. There are a lot of people talking about the pros and cons of telehealth counseling. And I think one major reason for that discussion is that when you discuss about genetic counseling and counseling skills, a lot of attention, I think maybe even in the courses that you do, is given to the face-to-face connection that you have between a counselor and a patient. And obviously in Australia, we don't do genetic counseling shadowing anymore. But because in a lot of other countries, that's another thing that they do. So how can telehealth genetic counseling, teach people how genetic counseling happens? So what would you say is the major difference between telehealth genetic counseling and face-to-face genetic counseling? And what are the few aspects to really pay importance to or attention to when you do telehealth counseling?
Yeah. I think it's interesting because I've seen in other health professionals a lot of discomfort around telehealth. There's a feeling that it's inferior to face-to-face services. I don't necessarily, my personal opinion is that it's not necessarily inferior, it's just different. And like with any aspect of genetic counseling, practice makes practice. You know, the more you do it and the more comfortable you become with the medium and the technology, and there's definitely been a change with patients becoming more comfortable with you know, video chat platforms, that's been a real key. Is the more you do it, the easier it gets. And being afraid of it because it's uncomfortable doesn't necessarily mean it's something that you won't build a skill in and get good at. I think we've all felt uncomfortable in face-to-face sessions as well. And I have to say the trade-off of having that that better building of rapport coming from a little bit of vulnerability, especially for me. This isn't a hospital office, this is my home office. And sort of, I guess, exposing yourself a little bit, opening up, I find that really can build a beautiful relationship, beautiful conversation. People meet my cats, I meet their dogs, their husband brings in a cup of tea. It's a different way of working, and I really like it. So I would encourage anybody who's not comfortable with it to do more of it. I think it's mostly the health professionals who are uncomfortable with it. All of the research that I've read says that patients really enjoy it. And I think our concern is that, well, they don't know how much better it is if you see them face to face. But I tell you, when you've seen somebody who's just spent half an hour looking for a parking space in a crowded hospital area and has trouble finding your clinic and rocks up 15 minutes late, they're not necessarily in the best headspace to receive what you're trying to deliver. So yeah, I think there's definitely pros and cons to both, but I don't think one is better than the other. I still do occasional face-to-face clinics and I still love them, but definitely it's just a different way of practicing. Yeah. And with telephone appointments becoming more common as well, I still think at least video conference is an improvement on telephone, because our technology for telehealth has improved so much over the years as well. We've got way less technical difficulties and issues with video quality and all that kind of stuff. So it's definitely improved on the ability to do that.
Yeah, yeah. So what are the few, I guess, skills, important skills that you find are very useful for you when you do telehealth genetic counseling?
Look, I think it's a lot of the same skills, and just really paying attention to those things. You may get less, I guess, slightly less visual information, but I think if you pay attention, that you can still receive that information. It might just be being a bit more mindful of that, and the fact that there might be limitations, or that there might be people for whom the technology is new or difficult to access, and building that kind of support into it as well. But really, I think the fundamental counseling skills are still the same.
Yeah. Okay. Great. So I guess one question that a lot of the students had after listening to a couple of the interviews was, you know, in terms of the workload that you have as a genetic counselor in your day-to-day life, how much time do you, or how much time are you actually able to make up for reading a case before it comes to you? Or do you actually don't get that time? Do you, like, you know, have circumstances where you have to read the case then and there when the patient comes to you? And how much time do you actually get out of your work to research and keep yourself updated?
Yeah, that is a really good question. And I think it probably varies pretty widely. When you work in a big department, the degree of administrative support that you get will vary. The expectations of what gets done by a genetic counselor or by a geneticist or an admin staff will vary. How much preparation you're responsible for, or perhaps a clinic where you might have an intake assistant who does that for you. I've been blessed to work with some amazing intake assistants over the years, and I cannot tell you how valuable they are. I think there comes a point when it's really important to eventually be able to run on the fly. There will be people who turn up on the wrong day and it's going to be impossible for them to come back, or somebody who needs to be seen then and there because it's an urgent situation. And I think that comes over time with your comfort in your practice, to be able to pick up something fresh and know that you can get what you need, the essentials pretty quickly, and cover off the rest either in the session or down the track. But it's not necessarily something people are going to be comfortable doing straight off the bat, and is something that I think you learn over time. Again, practice. And once you've been, I guess, thrown in the deep end a couple of times with some of those surprises, you get ideas about how well to prepare. And I think there's a real value in having colleagues you can access when there's something a bit out of the ordinary, as you're learning to be able to take those things on board, because we don't always have the opportunity to prep and research and have everything under our belts, and being okay with knowing what you don't know is, I think, really valuable as well. I would much rather say to a patient, I don't know, I'll find out for you and I'll get back to you, rather than try and come up with something that may not be accurate or may not be helpful, or not well formed. And I think people value that as well, that kind of honesty.
Yeah. Yeah, interesting. And I like the fact when you said that, not in most of the situations, yes, you would not know what it is, but it's always good to accept to the patient that I don't know, but I will find out for you, and I will be with you throughout the journey while we find it out together, and access what the resolution is. So that was a very good advice there. I think I just, while I was listening to, I had this very good, I guess, a exercise that I thought I could do with you. If maybe I can try on you. I haven't tried it with anyone else.
Sure.
Because I know a lot of times we as students, we do all these discussions and we ask questions, but I guess I just thought that maybe it would be a good idea if I could ask you to dictate, let's say, a scenario that we create, where you've got a new patient coming to you with maybe, let's say, one of the most complex kind of cancer. I guess you would be a good person to name what kind of cancer.
Okay.
Yeah, and they've come to you with their files. They've been referred to you by an oncologist or a doctor. So how would you start your session? What would you do in that session, and how long would your session be for?
Good question. I'll start with the last bit first, because that's kind of the easiest. I think it's about par for the course where most clinics will allow generally an hour for an appointment. And that, I think, really sets us apart from so many other health professions where you get 15 minutes, half an hour, in and out, done and dusted.
Absolutely.
And on top of that, the research into how much prep time we do and how much follow-up time we do afterwards. The genetics health professionals give so much time to that specific client and that specific case. But having said that, that's, I think, where the value is I would start any session, whether it's a straightforward something I've seen before, or something I go, I'm not really sure where I'm going to go with this and how much I can help, which I try to be really transparent about. If it's something outside of my scope of practice, whether it's as an individual or as a cancer genetic counselor, I'm quite happy to help people find the right place if I'm not the right place for them to be.
Yeah.
But I always start off finding out a bit about their story. I know when we're new, we rely a lot on having a really structured session, and there's nothing wrong with that, because it makes sure that you have covered everything you need to cover and have dedicated time to the things you need to dedicate time to. But I've found over time that it's become much more of a conversation, and I really like to hear my patient's story. Where are they at? How did they end up in front of me? What are the questions that they're bringing to the table? Because sometimes just being present and letting someone tell their story, I get so much of the information that I would have sat down on a checklist of questions and gone through and got anyways, but in a much more, I guess, comfortable way. And sometimes things that I may not have got from a direct question. So that's where I would always start. And I have to say, I love a good chat. So sometimes I go over time, sometimes I go under time. Depends on what we've got to talk about, but generally about an hour. And yeah, a good chunk of that first portion is just finding out the story, and that'll give me information about the pedigree. That'll give me information about their lived experience of cancer in their family, or of their treatment, and often helps to give me a really good idea of what the question is that they are looking to have answered. What's the biggest priority here? Because especially in private, we've got so many options for what we can offer. I could see everybody coming through the door and test them for a huge panel of cancer genes, but that's not always the right thing for everyone that I see. And so knowing what their question is and what their priority is can help me to work with them to come up with the best plan for what's going to be the most helpful.
Yeah. Perfect. I guess that is what I was looking for when I asked this question. I was like, I want to understand, do you like just, look at the reports and jump into the technicalities of it? Or do you, keep it more informal where you kind of set the stage based on the patient's pace of, coming to you and their motive of why they want to see a genetic counselor? So thank you again for living to my experiment, and I'm sure everyone's going to love this part. I think another situation which I think would come a lot more in cancer genetics compared to maybe the other areas of genetic counseling, because a lot of cancers can be hereditary, can be running in the family genes, and a lot of times the family can be at the risk of having that cancer, for which the patient has come to see you. And I know non-directiveness is a huge factor in genetic counseling. So do you often find a lot of cases where, you have a patient with cancer and you do the genetic counseling and you realize that the family might be at the risk, but, probably the patient does not want to inform the family, or the informed consent comes into the picture? Have you had these sort of complex situations?
Yeah, I have to say they're in the minority. I think most people that I would see are either having testing because it's already been done in their family and they want that information for themselves, or because they want to help their family somehow. And usually, even if it's, if the priority is getting information for their treatment or for their own risk management, it's often and almost always part of the conversation that I also want to do this for my kids or for my siblings, because then we can do something about this down the track. So the sort of default position is most people are actually surprised that we can't just share their information and share their results and get all of their records from everywhere without their permission. They think, oh, why you're a healthcare provider? Can't you just get all of my reports from all of my doctors? And it's not always that straightforward. And why wouldn't you just share this with everybody when they came in? So it is usually part of the informed consent is a discussion around when and how we will disclose the results. There are some legal precedents for a duty of care to unaffected family members. There can be delicate ways to do that. I don't have to say your mom had testing and this was the result. I can say someone in your family's had testing, and that means we can test you as well. Sometimes it's kind of obvious who that person would have been.
Yeah.
But sometimes getting people to open up those conversations with their family and have those discussions. It's things that they, maybe thought they had told them or hadn't realized they couldn't access, or it's in the minority that there are people that definitely don't want anyone to know about anything, but they do come up. And I think being really transparent about a bit like disclosures of abuse and violence. What are your limitations on what you can keep private and what you can't? And sometimes the question about, if you are having this testing, is there a point in doing it if you're not going to share that result. Yeah, and it's covered differently in different places based on legal requirements, based on policy, but can be a very tricky balance when, as often happens, families have lost contact or are out of touch. But I've also seen the impact of that when it does come to light, and when people who could have had testing hadn't and have then faced a cancer diagnosis. So navigating family dynamics and helping people with tools or strategies to communicate with family members, even if it's anonymous letters or things like that, is sometimes something we have to work through, and to try and make sure we're walking that line of duty of care to the person in front of us and duty of care to the other people who might be at risk.
Yeah. Yeah. Well, thank you for explaining that aspect, because yeah, that's a very I guess that's a very technical aspect, but also very psychological aspect that you just said, because it's related. It looks to me like it's kind of interlinked between legal rights of what you can do as a profession, as a licensed genetic counselor, but also the psychological aspect of how you go understand the family dynamics of the patient. And I guess you well explained it before, that happens only with having that informal conversation with your patient and understanding the reason why they actually came to you. So that was very fantastic. Thank you so much again for sharing that. I think my next question is, have you had a situation where you had to give an unanticipated outcome? Or you had
more and more often? It's happening all the time.
I think I got this question from one of the webinars of a university that I was attending, and yeah, they asked as to if you had to, as a genetic counselor, give an unanticipated outcome, or you had to deal with a patient who gave you an unanticipated reaction for a result or for a session. How would you describe that?
I think it's very important to deal with the potential for unanticipated results at the stage of consent. Because we know that things can come up that are weird, that we've never seen before, or that don't fit the picture that we were looking at in the family. And if I find that the reaction of the patient really will tell you how well you prepared them for that at the consent stage. So I think probably the two we see the most often in cancer genetics in these days is variants of uncertain significance. So variants in a gene that we know are different from the reference sequence, but we don't know if it's enough to stop that gene from working and cause a cancer risk. I use my Canadian background. I explain it like some gene changes are the difference between American and English spelling. Don't change you reading that sentence if color's spelt with a U or without a U. But some gene changes are actual spelling mistakes that mean that sentence doesn't make any sense and it can't work anymore. And if we don't know enough to know which way around that is, we can't do anything with that piece of information. And we often have to wait for research to catch up and tell us a bit more. And by preparing people for that, when I've delivered a variant of uncertain significance, they remember that we had that conversation, that what our plan was if one of them came up, and that we wouldn't be able to use it clinically. And they seem much more, I think it would be much more of a different conversation if that hadn't been raised in the first instance. And the same with cancer gene panels now, and also with private testing. Some people come in and say, look, I just want you to test all the genes for everything because I want to rule it all out, even if the chance of finding something is slim. And I will use the example of, if we're testing your family history is a bit of breast cancer, we're testing a bunch of different genes. What if we find a fault in a gene responsible for stomach cancer? And the recommendation is to take your stomach out, and you don't have any family history of stomach cancer. Seems a bit, a bit full on. And so having a think about whether people are concerned about incidental results in other things, what we might do with it. Plan might be to send them to a gastroenterologist to have a bit more of a discussion. And also being realistic about the limitations. We know that most of the genes that we found because we've studied families with really strong family histories. We don't really understand what that means in somebody with no family history of cancer. Our knowledge isn't perfect. And it's again that, knowing what you don't know and admitting what we don't know. Genetics isn't a perfect science. It's not black and white. It's not clear cut. It's a risk and numbers game. It's a bit like going to Vegas. So I think preparing people for those circumstances is great. I am always amazed at the resilience of people to cope with the results that they're dealt. People are generally strong and generally resilient and reasonably may need help to navigate through that. But it always amazes me. I've had people be really pleased to get a positive result that meant they were at a higher risk of cancer, because that means their dad wasn't the milkman. It's clarified the relationships in the family, makes them feel more connected to their family who've gone through some of the similar things. Yeah. I've had people, we call it survivor guilt sometimes, when a person's got off the hook in the family and maybe some of their siblings are on the hook or their parents are on the hook, and they might feel bad about being the one who's got off. For example, a sister with a BRCA gene mutation and the brother's a negative, and he wishes it was the other way around because it would have different implications for him. So this is also something I talk to my patients about, is anticipating your reaction to the results. And I just say, look, we've seen it all. And sometimes it's hard to know how you'll react until you're sitting there with that piece of information in front of you. And it's all normal. And my job is just to help you with that, whatever that reaction is. And you might have an idea of what you think you'll react like. Most people are preparing for the worst. And some can be quite surprised if it's not the worst case scenario, at least what they think the worst case scenario is in their own mind. So balancing that discussion of, it might be a reassuring result. We don't have to necessarily prepare for doom and gloom, but how will you feel either way? And setting them up to think about that while they're waiting for that result. Something you talk about a bit earlier on in the piece.
Well, thank you once again. I think the takeaway from this answer that you gave was about how you set the stage for anything in the session before the result. So I think the term that I was getting in my mind when I was also actually reading an article related to this was that genetic counseling is not just about giving the genetic test results to the patient, but it is pre-counseling, genetic testing, and post-counseling. And I guess that really sums up everything that you've explained just now, that it's more like you're a buddy and like a colleague with that patient throughout the entire journey of them moving from one stage to the other. But thank you once again for giving such good and beautiful examples out of your experience for every question that I've asked. I think we've come pretty close to the end of the interview because I know I really don't want to take up too much of your time either. But I think just two more questions that I have. One question is, obviously now we are at a stage where genetic counseling is getting to be known among people, and there are a lot of aspiring genetic counselors out there from what I've seen and from the ones that I've connected with. So I think we would like to understand what, as per you, you think are maybe the ethical issues in genetic counseling, and what, as per you, can be the future of genetic counseling.
I think the future is going to be really interesting. I think we're at a real transition point in the profession for a few different reasons. One is the sort of increasing shift of genetic and genomic technology into the mainstream. So into outside of the genetics clinic and into areas of medicine that don't necessarily have a genetic health professional working in them. I think that means there's a great deal of opportunity for particularly genetic counselors to support other healthcare providers in a multidisciplinary way. But there are barriers. We're not well set up for that. We're well set up to be a tertiary specialist genetic service with genetic counselors and geneticists that sits in usually, a hospital somewhere. We're not well set up to have genetic counselors supporting GPs or seeing people independently. And there's not a great setup for working in private. There aren't funding models that are well designed. So that's a lot of what we're working on with the HGSA at the moment. Mm-hmm. Is recognizing that practice has changed and is continuing to change, and the I guess risk to not supporting both the patients but also the providers in navigating the incorporation of genetics and genomics into mainstream medicine, because it's got huge potential for health and prevention, but it's also got huge potential for risk and damage if it's not done well. So I think that's a huge area that we're going to see. I think we're seeing it initially in the cancer genetic space because there are, chemotherapies and treatments in the oncology space that change based on a patient's genetic test results. So that's really key to have that integrated into the diagnostic pathway for cancer. I think the other place we're really seeing it, you might be aware of the Mackenzie's Mission project that is piloting preconception and early prenatal carrier screening for couples. I think there's going to be huge demand for that, and that's falling in the laps of the GPs who I think would value access to genetic counselors and genetic counseling support as part of that process. So it's going to be interesting to see the data that comes out of that study. So to me, those would be the areas that probably have the most potential, I guess, clinically and for independent practice. Mm-hmm. But what I've loved about working with the work on regulation of genetic counselors in Australia and New Zealand is that I think we're actually finally starting to recognize that clinical genetic counseling is not the only place where genetic counselors work, and that there's such a diverse areas of practice, so many different areas of practice that we fit into, and seeing that potential in research, in health education, in policy development, in the laboratory space. I think as those technologies move out into mainstream, the role of the laboratory genetic counselor cannot be underestimated. I have been one for a while. I was one in Vancouver, and even then it was fantastic and very well appreciated by staff and clinicians who were ordering tests and the patients who were accessing services. And I think that's also probably the way things will go in countries that maybe haven't had genetic counselors or tertiary genetic services and are just now that these technologies are coming on board in a lot of areas of medicine are looking at how do you gatekeep, how do you access genetic counseling services, where is your point of care? And I think the lab is a big one. So I think there's a lot of potential for growth. I think, however, systemically, we've got to catch up.
Yeah.
I think it's often been a problem that genetic services, even in the traditional sense, are under-resourced, but they are fully staffed. Every position that they have money for is filled, but the piles of charts are huge and the wait lists are long. And I think that looking at appropriately resourcing and funding genetic services, whether they're in a specialist clinic or in other clinical settings, I think is going to be really important. So I'm interested to see where that goes. And I think we're predicting an increase in demand for genetic counselors, which is why we're kind of trying to make sure we're getting more people through the courses. I think we're going to see more collaboration internationally. I think jumping borders like I did was not easy, but it is getting better all the time, and we're working really well with our international colleagues to try and make sure that there's pathways for people to do that so that people can go where they're needed. So I think it'll be really interesting to see how that develops over time, but I think it's a really pivotal time for the profession, a really exciting time to get involved.
Yeah, it is. Yes, I'm not in the course, but I'm already very excited from whatever I've been learning, and I just can't wait to be a part of your network. I can't wait to be a genetic counselor. And I think this is a very personal front, but I think I've started to, when I was reading about you, there were two things that made me, feel that you were my right mentor. And I'll say that why. One, because I, like you, want to, in future work in more than one country. And I really wanted to know, how can I do that? How is it possible for me to do that? And second was, I wanted to, at maybe when I turn 40 or 50, I'm not sure. But at one stage, when I've had enough experience, I did want to actually open my own genetic counseling clinic. And you do that thing as well. And I would really appreciate it if maybe you could share some tips or your journey on how you went on creating or actually opening your own practice, and what all did you need to do that?
Yeah, look, it's not straightforward. There are definitely barriers and limitations and challenges, and I have to say it's still, only a kind of a year and a half in. It's still early days, and I'm learning a lot. I'm learning a lot as I go. I think I've been very lucky to have the support from, I guess, some people who've been my colleagues for years, who also count as really good friends. And as well as sort of the multidisciplinary team that I built up over the years of working in the public clinic here, is knowing that I've got people to access when I've got questions, whether they're logistical or supervision questions around how managing a case, that kind of thing, has been really valuable, as well as maintaining my connection to the professional organization. I feel so connected to so many of my colleagues around the country, which I think is wonderful. Yeah, look, logistically, I have to say it's a bit of a question mark. When you get to the point of doing it yourself, I hope there are clearer pathways. I had to navigate, choosing a lab that would accept a request from a genetic counselor, because we don't have provider numbers, and coordinating how I was going to deal logistics and shipping, and even the context of my genetic counseling is a bit different in a private setting where we don't have eligibility criteria for certain tests, and that's changed sort of the way I can approach things, and how I actually go about providing the service when I've got all of the options available in the world. Even things like learning about your value and billing is a whole nother ball game for somebody who's been in public service for like over 15 years. So it's been a real learning curve, and I just have to say I'm super grateful for the professional support that I've had, the opportunities I've been given to put my fingers in a lot of different pies and get my feet wet doing a lot of different things. I feel really valued by the people that I work with, and that's been fantastic. But tips and tricks, I think having a really good foundation clinically before starting off on your own is really important, as well as maintaining that support system. Even if you are effectively practicing independently, that doesn't mean that you're practicing on your own.
Yeah. Well, good tips there. So networking and having a good foundation. And yes, that is what I think we all have learned about genetic counseling, that it's a very collaborative role. You have to be, I've often heard people using the term people's person or persons. Yeah, I think that was people's person. And in the initial stage, I guess I was like, what does people's person mean? But I guess now I understand it more and relate to it more, that, it's a role where you have to have good relations with your colleagues, and with this genetic counseling network that we have across the country and also across globally. Well, thank you so much, Amy, once again. And just before we end the session, I think the only one last thing that we all would love to know from you is, what does genetic counseling mean to you? Or what is genetic counseling as per you?
Oh, wow. To me, genetic counseling is, I've described it as being a translator. I've described it as being a facilitator. I think I've used the word navigate a lot of times today. And I think that to me is really where I get the value of what I love of my job, is helping people navigate the world of genetics and genomics, whether that's in a clinical sense or in another area of professional practice, so that they can use that, so that we can all use it to make things better.
Yeah.
That's what it is to me. And that there's a great deal of reward. It's not always easy, but there's a great deal of reward in feeling like whatever you do in any area of genetic counseling practice, you're making a difference.
Yeah. That's a big takeaway again. And I think most of us who are looking to become a genetic counselor would completely agree with you and relate with you, in the sense that, yes, this is one of the professions where, like you said, it's not a 15-minute session between, like how, normally it is between maybe a doctor and a patient, where the doctor just tells you, okay, this is what I prescribe, go and just take it or do as I say. But yes, genetic counseling is more of a personal touch, and a more of a friendly conversation and a relation that you share with every patient that you see. It's it is about making a difference in a patient's life, and it's about prevention. And I'm so glad that something like genetic counseling and genetic testing is growing and there's more emphasis on it, because I clearly cannot make people understand enough the importance of having a genetic test done. If you know someone in your family has a condition and it has been a pattern, then it is so important for someone to go see a genetic counselor and find out more about it, so that they can prevent it from happening to themselves or someone in their family. So thank you once again so much, Amy. Thank you once again for your time. Well, I'll let you go now for your fitness class. I'm sure you're so looking forward to it. Thank you once again.
Thanks.